Alrighty, thank you everyone for joining us. Again, if you missed me, introduce myself. My name is Alexa Hawley. I'm the event specialist at Care Compass. At 12:02, I see some people are still coming in, but I would like to pass it to Mark Rapecki at this time, and then we will take it away.
Yeah, thanks, Alexa. And we are recording this, so we'll make this available to people that might show up late, but we just have so much to talk about. So we want to be able to get started and finally be able to greet you all as the social care network for the Southern Tier region. It's been quite a journey, years and years of watching District 2 and different evolutions of the waiver, and then the state procurement process. And as you likely have seen because you're here, we recently received notice from the state of our award and finally have some updates to share on the waiver. We've been actively working with the state. There's still some things that are taking shape and are draft. There's some things that are becoming much more clear. And so this is, in case you're feeling like this is moving so quickly, I'm not sure where we're at with things. This is our very first official kickoff call, I'll call it, for the work of the Social Care Network. So this is ground level. This is going to be our first, I'm sure, of many different all stakeholder calls. The goal for today is very, very high level. There's a lot of details to swim into, and we won't have time to dig into them all today. So today is just general orientation. I guess college is back in session, right? So it's probably appropriate to call that. This is orientation day. And so I'm happy so many of you have joined and are here. One other preface is all of these slides we will make available. So if you want to screen grab and take notes, you can take your notes, but this is being recorded and these slides will be distributed after the meeting. There's some links in here and as many resources as we could make available. So to kick right into it, Alexa, you can go to the next slide. Goals for today are very, very high level. Some of you might be new stakeholders. Some of you have worked with us for many, many years. But really, the goal for today is to give a high-level overview. You know, what are we hearing from the state that we can share with you? What are some new updates that we're seeing? There's things like the state has recently given Care Compass an operations manual for the social care network, which we were really excited to see. However, it's draft and being negotiated with CMS, so they very explicitly said you cannot share this yet. So we're seeing directionally some of the things. We have permission to talk directionally about where the state is going, but there is still more information that we'll be getting as time comes out. So we want to go through some of those updates with you today. And then also related to the waiver, we've been waiting and watching for a while about workforce investment organizations. It's another domain of the 1115 waiver. And very recently, within the past week or two, the WEOs from New York State have been announced. And I'm happy to share that Tasha from Iroquois is here and is going to give a welcome and overview on their initial planning and thinking, as much as they also have some things that are draft with the state. So we're happy to have Tasha come and speak on the WEO side of things, and that's the WIO acronym. And then give a very high-level overview of some of the functionality of the social care networks. We want to cover the care delivery model so you understand, what is it that the SCNs are going to be trying to do, the social care networks. Also, an introduction and an overview to the technology platform that's required for the work of the social care networks. And in our case, we've selected a system called Unite Us, and so give a little bit of an overview about what that system is intending to do. And then also for the administrators and the executives out there, what is the approximate roadmap to contracts? I know everybody has different contracting cycles, and the sooner we can share some of that information helps you prepare. There's many, many more things we can cover in future meetings. We'll talk about just high-level next steps, things that we're waiting for to see. But even just this general high-level overview will probably take us a good portion of the way through the hour. So Alexa, I will ask you to go to the next slide, and we'll just dig right in. This is not a new slide. This has been out since January of this year. But in case you're not familiar with it, the 1115 waiver is multifaceted. Care Compass is going to be focusing a lot of its presentations on the work of the social care network. And there's two different funding streams there that are just helpful to be aware of. But as I mentioned earlier, there is also a workforce component to this waiver. And that is separate and apart from the social care networks. But I think it's helpful that you know the 1115 waiver is not exclusively about social care network activities. It's a big piece of it, but the WEO piece is also significant. So again, Tasha will be able to speak to that component of it later. There are other aspects to this. We have not seen or met with the Health Equity Organization. The statewide Health Equity Organization has not been released yet, to my knowledge. If you've seen them, let me know. And then there's also some budget dollars for hospital incentives, but that's more of a New York City thing, so we won't be covering that much at this time either. So that's a summary of the 1115 waiver. Alexa, you can go to the next slide. We get a lot of feedback on acronyms and how many of them are prolific and forming. And I've tried my best in reviewing all of this content and realized it is near impossible to walk through some of these things without making reference to these four specific acronyms. So before, and I've already used WEO and we're jumping into it, but before we go into any of the social care network overview, I think it's helpful just to understand what these are. Community-based organization. There's been a lot of definitions to CBOs over the years, and in DISRIP we got into the tier 1 CBOs and the tier 2 CBOs. We had all these different layerings that the state was putting on it. For purposes of this waiver, the current definition of a CBO is here. This was in the RFA itself, and it's a not-for-profit charitable organization that works at the local level to meet community needs and is a 501c3 organization. So typically, how we might work in the community, if you're a for-profit organization, but you work with the local community, you're a CBO. We've had a lot of different definitions. For purpose of the social care networks, this is the definition that the state is using. I'm not seeing the layering, the tier 1, the tier 2, those kinds of things. We've seen an evolution from SDOH kind of emerged and got a lot of press the past few years in particular. And for purposes of this waiver, we're now focusing on health-related social needs. We call them HRSNs. And these are the drivers of health outcomes that directly impact health inequalities, including but not limited to nutrition, housing, transportation. So you hear us talk a lot about HRSN services, and that's really correlating to food insecurity and nutrition assistance, housing assistance. You know, broadly speaking, those are under the domain of health-related social needs, or HRSNs. Also, social care networks. This is a new entity that was formed. It's a vehicle for this waiver to coordinate HRSN services. So you'll hear that the SCN is working on HRSNs. And again, I know I'm trying to acclimate myself to them all, and I'll tongue-tie myself at times, but this is the kind of language that we're getting from the state, and we're doing our best to parse it out. The last one here is enhanced services. Within the work of the social care networks, a big piece of it is going to be the coordination of new billable Medicaid activities, which they call enhanced services. These have not formally existed within the Medicaid program previously. Synonymous with enhanced service would be level 2. So a level 1 service would be all of the existing billable Medicaid activities in the community today. And now we're adding a new layer, a different level. These level 2 services that are new are called the enhanced services. So the social care network will be addressing health-related social needs by deploying enhanced services is the approximate framework of this waiver. Perfect. Alexa, you read my mind. I was going to go here. So if you've not read the waiver and you've not seen hundreds and hundreds of pages, this is your cheat sheet. This is the Cliff's Notes of the framework. And I'll walk down this, and this will just be a quick introduction to the work of the waiver. And then Tasha, I think we're going to hand off to you for some WEO updates after this. So if you've not read the waiver, the enhanced services, these are the new Medicaid billable activities that will start approximately January of 2025. There's a lot of things in process. There's a lot of things not yet in place, but the state's very firm, very aggressive target is that they want to see these enhanced services beginning January, no later than January of 25. It's important to note that the enhanced services are not available to everybody. There are qualifying criteria. So they are only available to a certain eligible population, which varies based on what the service is. And we will go through these services later. They're in here. Enhanced services, these have already been predefined by the Department of Health. For those of you that were here for DSRIP, there was a panel of projects. We got to pick projects. It was based on community need, and there was a little bit of flexibility for the PPSs to do that work, or the entities that did the prior DSRIP program. In this case, these new services, they've already been picked, they've been defined, and the state has already handed them to us. In addition, the enhanced services are going to come with a fee schedule. So that's something that the state is also working on. We've not seen that yet, but for each one of these new enhanced services, there's also going to be a defined fee schedule that the state gives us. So for those of you previously with DSRIP, there were sign-on bonuses, or we had flexibility to adjust our rates. In this case, it's all coming pre-packaged, so to say. Organizations who deliver the enhanced services will be reimbursed by the social care network. So the social care network is sort of the regional distributor of funding for the delivery of the enhanced services. I said earlier that the enhanced services are only available to eligible populations. One of the ways that we find out who's eligible for an enhanced service is by conducting a health-related social needs screen. So again, think we're covering domains of housing, we're covering domains of transportation or food insecurity. To determine who's eligible, these screens will need to be conducted. One of the early metrics and measures that the state will be holding the social care networks accountable to is how many of these screens can get done in a given year. But the broader vision is that every Medicaid member in a region has a health-related social needs screen conducted each year. And any organization that conducts these health-related social needs within the social care network IT platform would be eligible for reimbursement. In addition to the enhanced services and the screens, another element, and this is very front-loaded in the waiver, is going to be infrastructure funding. One of the goals of the social care networks is to ensure that Medicaid members have access to these new enhanced services. And in some communities, in some towns, there might not be the enhanced service delivery available. And so the social care networks have the ability to use infrastructure funding to build capacity or build availability of these services across the entire region. To develop that, we've already done a number of initial surveys back at the time that we were filling out our application. We're trying to gauge, what are the needs in the community and hosting focus groups. Things change, and so we're going to want to leverage more real-time stakeholder focus groups and even comprehensive surveys to really evaluate what service capabilities exist or don't exist across the region. And that'll be one way to get input around where the infrastructure funds would need to be deployed to make sure we have service availability across the entire region. And the last one is a closed loop referral system. There's a requirement to have an IT platform for the social care network. We went through a vendor assessment process earlier this year and selected Unite Us as the system that would be supporting the social care network if we were awarded the application. And so along with rolling out these enhanced services and screens and all these things, we'll have to be getting organizations onboarded to this system so they can connect in to the work of the region. So this is at a very, very high level, and we'll dig in more later, but this is sort of the rough roadmap of the core elements of the waiver. there's a lot there's a lot underneath each of these qualifying conditions and timeliness of service delivery and all the things that you'd expect. The current operating manual that we received was near 200 pages, so there's a lot more that goes into this, but this is the high level concept of the core principles around the waiver. I'll dig into more of this later, but for the first time, we're so excited to be able to hear about some workforce updates. And Tasha, really thank you so much for joining us today. I'll go on mute and ask Tasha to greet the team here. We're up to 109 participants from Iroquois. Thank you, Tasha.
Hello, everybody. I was about to say good morning, but it is afternoon. So good afternoon, everybody. My name is Tasha Grimmer. I work for Iroquois Healthcare Association, and we were awarded the WIO, the Workforce Investment Organization, for the upstate region. So Iroquois has a long history. Iroquois is a trade organization that represents hospitals in upstate New York. Currently, we have about 52 members. So our primary purpose is really to advocate on behalf of these hospitals, because as we all know, downstate gets the loudest voice, but certainly the needs of upstate are very different and very supportive. So even though I work with Iroquois Healthcare Association, everything you'll see here today is going to be under the name Caring Gene Healthcare Career Pathways. When the Department of Health approached Iroquois Healthcare last fall about being the WIO for Region 2, they did require that we establish a separate nonprofit in order to avoid a conflict of interest with our board. So the Caring Gene name comes out of the earlier DSRIP funding and then that 2018 1115 waiver. During that period of time, Iroquois Healthcare ran a program focused on long-term care and supporting the workforce in long-term care, especially training CNAs, for example. And in trying to get the word out, they worked with a marketing firm that designed the Caring Gene based on the idea that if you have an intrinsic desire to care, you have the Caring Gene and we have a job in healthcare for you. So for this program, which around the office we're calling WIO 2.0, we're using the Caring Gene branding idea, but applying it to this WIO. So Alexa, if you could go to the next slide, please. Thank you. So this is the area that IHA represents, and as you can see, it's North Country, and you'll see your counties are represented there. And those are the hospital systems that we've worked with. But like I said, based on the earlier program, we've also established a lot of relationships with long-term care facilities. Next slide, please. So here is an overview of the workforce investment or career pathways training that's outlined by DOH. So the 1115 waiver established this career pathways or CPT program to be administered by 3 WIOs across New York State. So Iroquois Caring Gene will be the upstate region. Just announced last week, so this is our 1-week anniversary of being officially named. And the Western region and Finger Lakes region will be represented by FLIPS, which is the Finger Lakes Performing Provider system. And then downstate will be covered by the 1199 Training Fund. So all 3 of us have $646 million for the next 3 years that was scheduled to start March of 2024 and end March of 2027. So clearly downstate will take most of those funds because of their high population, but we have generous funding for upstate New York. This program will support multiple providers, so we're not strictly confined to either long-term care or hospital systems. It's really any provider, healthcare provider that serves a 30% Medicaid and or uninsured population. So that will be a lot of places that we can support. So the program is divided into 2 separate tracks. Anybody who's new to healthcare, so that could be that traditional college student who's wants to be a nurse or wants to be a respiratory therapist, those students can be supported. And it could also include that returning adult. So for example, we have started talking to a group in Syracuse that supports newly immigrated adults to the United States who may or may not have had a career in healthcare before moving to the United States, but need to get credentialed in New York State for that path. We can support that student. The second group are those currently employed in healthcare who want to advance their career. So the LPN who wants to go to the associate RN, or the associate RN who needs to complete the BSN in 10. So those kinds of students can also be supported. In return for this generous scholarship funding, the student needs to make a 3-year service commitment to a Medicaid provider that serves at least 30% Medicaid and or uninsured. So next slide, please. So our funding flow is from New York State through the Department of Health, and it will go out to each of these 3 WIOs. So in addition to just supporting in terms of scholarship dollars, we are required and will be doing case management of these students. So really walking them through everything from applying to a program to receive a certain credential, or if they're already in a program. And part of this will definitely connect back to the social care networks, because any Medicaid eligible student may need to take advantage of some of the supports that the social care networks offer in terms of nutrition, housing, transportation, etc. These dollars will go directly to an educational institution, so it will not go to student hands, but we can cover full tuition and any program fees. So for example, those lab fees or things like that show up on a tuition bill. It will also cover textbooks, and when they've completed their program, it will cover licensing exam fees. For the advanced career students, we are able to provide backfill to employees. Unfortunately, right now, the rate is very, very low and not really comparable to what a provider would need, but it is something. And it covers up to two work days per week that we could provide that backfill. So that is sort of an incentive for these providers to supporting their employees to go back to school. They can get some support there. Next slide, please. So these are the 3 WIO sections. There's one mistake on the map here, but the dark blue is what Caring Gene Iroquois Healthcare will cover. So all of those counties. It does include Tioga County and Tompkins County. They're accidentally the wrong color blue. So that lighter blue will be covered by FLIPS, and the orange is covered by the 1199 downstate. Students can move among the WIOs. So for example, you could go to school in Albany, New York, but then do your service commitment in Rochester. That's fine. We are, the criteria is that 30% Medicaid. It doesn't matter where you actually end up doing the service commitment. And next slide, please. Now, these are the healthcare titles that we can support. So in the nursing section, it will be those LPNs, the associate RNs, the RN to BSN, and nurse practitioners. Under the professional technical, physician's assistants, and then quite a bit in mental health. So the licensed mental health counselor, the master of social work, and the alcohol and substance abuse counselor. Certified pharmacy techs are included, and certified medical assistants and respiratory therapists. In our initial meetings with our hospital members, they have asked for additional titles, and we have applied to DOH about those. They are willing to consider, but not for this first year, so year 1. So for year 1, these are the 13 titles we can support. The last category are those frontline public health workers, so community health workers and patient care managers. So kind of a non-clinical role, but yet very essential. And I haven't talked to Mark about this, but I think there's room that we could, if you are hiring community health workers, we can support the training for those. And next slide. So this is a little bit overwhelming, but here's what we're imagining the student journey to look like. So we are responsible for the recruitment and identification of these students, and we're going to be using lots of different pathways for this. For example, social care networks may refer students. Local workforce development boards may refer students. Certainly the high schools and the college financial aid offices and any other community-based organization that works in the workforce area. We're working on launching a website called caringgene.org, and all the students will be filtered there. We will do an intake interview with each of them to make sure that they have met certain criteria. So for example, they must be a US citizen or an eligible non-citizen, and they must be 18 years old. In addition, in order to receive funding through this program, students will have to complete the FAFSA, the Federal Financial Aid application, and any Pell grants, which are the federal dollars appropriated for higher education, or TAP, which is the New York State, must be allocated first, and then we can be the last dollar in. Those grants do not ever cover textbooks, so we will pick that up as well, because they are eligible for that. We are going to use a case management system, so our case managers will be working with students to do those onboarding tasks, including getting accepted into a program if they haven't already been accepted, and then making sure the students are aware and understand completely the service agreement. So that will be the big part of the initial conversation and development with those students. Then, as part of our case management, we're working with HealthStream, so students will have access to HealthStream courses. They offer a lot of modules and mini courses and subject areas that students may need support. So for example, anatomy and physiology keeps coming up as a really difficult course for a lot of students. We can supply some of those courseworks through HealthStream. In addition, there are also HealthStream courses just to help that adult learner. How do you take notes? What's it like to take an online course for those of you who've never done it, etc. So we're building in a lot of supports through HealthStream. We also plan on working with other community-based organizations. So for example, the local workforce boards that may have some supports for students that would help them be successful academically. At the same time, we're working with providers to provide those backfill payments for their current employees, for those in the advanced pipeline. So then we're really excited because in addition to getting them through academically, we will also pay for their licensing exam fee. HealthStream offers courses to support those that need that licensure exam so that we hope to have a high success rate of passing those exams. And then students graduate and we support them through that early workforce process. So finding them a job that with that approved provider that serves that 30% Medicaid population. I'm getting tongue-tied here. And then keeping them engaged in that 3-year service. And next slide. So right now, very similar to the social care networks, we have been forbidden to speak about this, forbidden to make any kind of formal partnerships with people in the outside community, but we were publicly announced last week. So we're hitting the ground running, especially because we're bumping right up against this fall semester. I'm not sure how many students will be ready to support this fall, but definitely January, we're going to be hitting the ground running. So we've been talking to local BOCES and high schools, the 2- and 4-year colleges, the SUNY system schools, trying to get those memorandum of understandings up and going for tuition reimbursement and then the textbook and supplies purchasing. We're just getting ready to advertise for our case managers that will end up recruiting and mentoring students through this program. We have hired, I'm glad to say finally, something I can say, we have hired a marketing manager who will be getting this out in the public and getting all those good campaigns going. We're developing our our educational learning management system and working with HealthStream on that. That will also be part of that website that we launched, caringgene.org, and starting to talk to partners about reimbursing for their current staff. And then we're not ready to be here yet, but we'll be quickly getting those students into the job market, into the workforce in healthcare, and start that 3-year service commitment. And I think that might be my last slide. Oh, contact information, of course. So similar to what Mark explained about the social care networks, we have received one draft of a guidance document from DOH. I'm a little jealous because it was only 30 pages long and Mark got a 200-page one. So there's still a lot of unanswered questions that we're working with DOH, but we're really excited to get this program launched. We love the concept of it, and we're definitely excited to get this rolling. So I see a question came in from Lisa. How do we establish a partnership with you as a Medicaid provider? Definitely send me an email. The memorandum of understanding for that is not yet written, but it has gone to our legal firm. So those are coming. And we would love to set those up and have a place for students to go as soon as they are credentialed. Another question came in, what is a backfill payment? So if you are currently employed with a healthcare provider and you have, your 4 days of shift work that you're scheduled for, but you need to take 1 or 2 of those days off in order to attend a class or clinical rotation, we can support so I come from education, the substitute teacher. We can pay that substitute nurse or substitute LPN for the time that a regularly scheduled employee needs to be out of work in order to attend class or a clinical rotation. Next question that came in, expanding the titles for CNAs and home health care. That is definitely has come up with DOH, and yes, we have asked about those specific roles. In addition to ultrasound techs and radiology techs, that comes up over and over of being a high need in the workforce. If you have other titles, definitely send them my way because we will advocate. All right, then I think I'm going to pass it back over to Mark.
Yep, thanks, Tasha. And I've already spoken with Carol Tegas. She's
Yes.
the executive at the Finger Lakes PPS, and they are willing to come to our next meeting. She had a conflict for today, but if you know Carol, she sends her love and is excited to come and greet the group and share similar updates. But Tasha, thank you so much. We've been waiting for a while to see what comes out of it. That was a very, very informative overview. Really appreciate you being here today.
Oh, I'm glad to be here, and I'm really glad to get this project launched. And I think it's going to support a lot of people and help a lot of providers.
Mark,
Alexa, you can go to the next slide.
sorry, another question came through.
Oh, yeah.
It's in the Q&A box. It says, when you said funding might be available to train new CHWs, do you mean informal CHW certification program or regular on-the-job training?
Those are both good questions that we have asked DOH because that title in particular doesn't have a certification definition. We are trying to support as many students as we can for this fall. However, Mark may be able to jump in here too. We have actually not received any dollars yet. We're in a contract pipeline with DOH. So I certainly can't promise for this fall, but I can definitely say for January. And I would love to talk offline about that community health worker because we need information too, and I would love to support that position.
Yeah, Tasha, we're in the same position at this point. We received an award announcement from the state, and then we've been going through a contracting cycle. The contract is not yet complete. After the contract is approved, then we have to wait another cycle to receive payment. So we're still in that same boat of getting started, and yet we're still trying to get started with the work out in the community as quickly as we can. Any additional questions in the submission box, Alexa? No? Okay. Well, more questions, keep sending them. If you send a batch of questions to our team, we'll pass them along to Tasha, or her email was in the slides. Feel free to reach out directly. But we'll try to work very closely with Tasha and Carol over the next few months, just to make sure there's consolidated updates and all relevant updates are shared, so that you don't have the chance to miss out. And also be aware, Tasha, I would imagine, as there's key dates, make sure you get this in by this date. We'll make sure that we include those in our updates as well, so everybody sees them.
Sounds good.
Tasha, maybe one more. There's a question. Can you speak on the for-profit CBOs? Is it NPOs only? Oh, that was Aaron. Was that for the social care networks? Yeah. So I gotcha. So for the social care network, the definition of CBO is a not-for-profit organization. However, if there is a service that's needed for the population and the C3 community doesn't provide it, the social care networks can work with for-profit entities. So it is possible. It's a very simple process as the state's defined it in the manual. We just have to have a process of evaluating it and submitting it. So basically, they want to have the primary focus being working with C3 not-for-profits, and then rather than invest infrastructure funding, if there's services already there, we could work with for-profits. We just have to have a methodology of how to go through that. But it is possible for for-profits to work with the social care networks. Alexa, you can go to the next slide. Okay, this is a busy slide, and I've peppered it with red font because I can't share the operations manual yet, but I can include supplements to publicly disclosed documents. And this is busy, and I apologize for it. I'm going to try to navigate through it. But the header here, I think, speaks volumes. This slide overviews the care delivery process that's going to deliver the budgeted $3.2 billion statewide. So this is very, very important to understand in terms of concept and workflow. I went through at the start of the meeting, there's enhanced services. The way that you get those enhanced services is by doing HRSN screens, the health-related social needs screens. And this is just an illustrative of how that workflow would go. So on the front end is a consent. And so the state is talking about within the HRSN screening tool that they've developed and adopted. It is a standardized tool that they would add at the front end of it, what they're calling question 0. They already have defined questions, but now they're adding one at the front end of it, which is a consent to do the initial screening. The screening completion is a reimbursable activity. So you see on the front end, you do the screen, you obtain that consent, you document that within the system, and that is one reimbursable activity. Now, it is possible to have somebody in your organization who just does the screens, but doesn't provide the back-ended service. So it doesn't have to be longitudinally the same person that does all of these activities. Separately, there's a determination of eligibility. So somebody might have a screen and they screen positive for food insecurity, let's say. Not everybody that screens positive would be eligible. You have to go through the eligibility criteria to see if somebody's eligible based on clinical need or otherwise. And the system should facilitate that quite easily. And then there's this division. Okay, so somebody has screened positive. How can I refer them? Well, the first concept is if somebody screens for a need and it's already provided in the community through existing services and infrastructure, you navigate them and refer them to those services. So existing clinical services, and the state describes it here, federal, state, and local infrastructure. You want to take advantage of those offerings first. We've yet to see the final models, but in some cases, you might need a consent to send somebody to another organization or to share their information with that organization, and in some cases not. But the referral to those services is a separate reimbursable activity for that navigation. If the individual is eligible for one of the enhanced services, it then sparks a secondary consent to say, hey, you've screened, positive, you're eligible for this service. We'd like to, send your information to this organization to provide food support. Would that be okay? The state has talked about this phase being a documented verbal consent, and we're waiting to see the reimbursable activities on that side of it. And then ultimately, when you have an enhanced service that gets delivered, that is also a reimbursable activity. So you may have, one singular person, doing multiple steps along this journey, or you might have somebody who does the screen and the referral, but they're not going to do the food delivery, or they're not going to provide the housing intervention, or they're not going to provide the transportation assistance. So there's going to be a connected layering of the community that's going to pull all these different pieces together. Bob Carangelo, our finance director, helped me map some of these different pieces out earlier. I'm going at a very high level through this. I was going to jump into the enhanced services next, but wanted to pause and see if there's anything else on this that you'd want to call out.
Yeah, Mark, those referrals are reimbursable under the under care management, which is going to be billable in 30-minute increments, according to New York State. So that is how those referrals will get billed in the future.
So goal for today being high level. Here's the workflow. Here's the steps along the journey. We can have a whole separate workshop just going through either one of these steps. So this is just giving you the overview to the key steps and functionality. Alexa, if you go to the next slide, this is a summary of the enhanced services. I mentioned it earlier that these are predetermined, they're already written up. There's more detail here, but just to see examples of the kinds of enhanced services that are here, we wanted to include this. I don't have time to read through all of these in great detail, but some of them you can see under the housing domain. You have community transitional supports. This is one-time transition and moving costs, including things like security deposit, first month's rent, brokers' utilities, utility activation fees, movers, really about helping individuals getting into stable housing, and even with utility costs and rent assistance. Alexa, you can go to the next slide. There's a lot of these, so I'm going to go quickly, but just to give you an idea, there's also home remediation. If you think of somebody who might have a qualifying clinical condition that's being exacerbated by mold or by pests, this would allow for home remediation. I think the state has come out with a lot of housing supportive programs this past year, and conceptually, some sheetrock repair or pest removal is, more economical than building new facilities across town. But you can see, multiple different kinds of new interventions here that would be identified by the screen and then secondarily supported with the enhanced services out in the community. And Alexa, I think there's one. Is there one last slide here? Yeah, there we go. And then this is last one we cover into nutrition. We're waiting to see additional definitions on transportation. There were two prior slides covering multiple domains on housing, multiple domains on food and nutrition, and then a fairly generic overview on transportation. So this is one that met with a mobility management team earlier last month. And we're looking to see how to define this a little more clearly. But even on the nutrition side, you're looking at cooking supplies for meal prep and pantry stocking, and just a lot of additional supports. And some of them do have time-bound limitations, so 6 months and things like that. I'm gonna hand off. We're down to almost our last 10, 15 minutes here. This is a high-level walkthrough. Again, there's gonna be a lot more to come, but just wanna make sure everybody sees what are the services, what's the approximate framework of how they go. I'm gonna hand off to Ken Green, who leads the IT function for Care Compass, and share a little bit about the closed loop referral system, Unite Us. So Ken, take it away.
Hey everyone. So we're going to talk about the Unitas platform as far as like the core functionality that is required by the state through the waiver release and specs. So if you can go to the next slide, Alexa. So the big question is, why did we pick this platform? Well, it met most of the mandatory elements that are in the waiver, and some of those include the document, the consent. I will let Mark talk about that one. There's a question mark.
Yep, I think please submit a lot of those questions, and we'll review specific uses outside of the operations manual. So Karen, we'll get an answer to you. And if anybody has other similar questions like that, we do have a resource desk that you can send things to, because these very specific questions, there's a lot of them out there. So we'll look and see how specifically it says things as written today. But the caveat is that the operations manual is still draft. So I can give you an answer and we'll share it with the group, but then it'll be subject to the final operations manual when it comes out.
All right, so some of the core functionality that was in the waiver for the centralized system, and the big push by the state is they want this all centralized. So they're when they do analytics on it, they're comparing apples to apples and not having to convert a lot of data that could mess up the actual numbers. So the initial steps is they document the consent for a screening or referral service, display the member information, including eligibility. So we'll hopefully be getting the eligibility from the MCOs through our qualified entity, which is the RIO, or in our case, Healthy Connections. They'll display all the previous screening and referral data for that member. So you can see what referrals are open, which ones are pending, and just see like in a previous, they screened positive for housing, but in this one they didn't. So it's a successful case. They're going to collect the New York State approved screening data. And that's where they're really going to standardize is across the screening data, because everyone's going to be asking the same questions and sending the same answers to the qualified entities on the Shiny and the NICE, who is the data lake for the state. This is a true closed loop referral between the navigator. Navigator can send out referrals and receive referrals from within the same platform. So the hope is that as referrals are sent out, you can send them specifically to a specific partner, or you could broadcast it so any partner who has availability could grab it for you. Ability to view and update the referral status, because as Mark said, there are time constraints around these referrals, and the hope is to get them viewed and updated, and if not in process or closed within a 5-day period, is what we're hearing so far. Ability to add notes to a member record, so turning into a true care management platform for the most part. Tracking members' progress is a big push as well. And then at the end of this, the system is going to generate the claims for the CBO, so it bills the SCN directly. So for any eligible or billable services. So we're hoping that we're trying to get that as automated as possible, so you don't have to actually go in and submit one of the 14 pages of SNOMED codes that we've got so far, which are the billing codes that were assigned in the guide. So who is the intended user for the SCN platform? Is all of the partners who are within the SCN who are contracted to do services, whether they're screenings, do the enhanced services, make referrals. That's who the intended user, and that's we're going to push it out to all the partners within the area. We have all the licensing through Unitas, so it's not going to cost anything to the partners. And our goal is to onboard them, give them as much assistance as they need to get on board and using the system, and just make it as user-friendly as we can. That's the best way to put it, because we know there's multiple documentation sources now. So as we're onboarding people, we're going to actually, we've already been working with Unitas to come up with the training plans on how we're going to onboard members. we're going to provide all the reimbursement for staff time and as well as onboarding, staff time for training and onboarding. And then we'll be doing follow-ups to see what's working for the systems and what's not working for the systems. And we're going to try to do continuous improvements as far as the platform is concerned. And actually next week we have a demo scheduled that everyone's invited to. You just have to contact Dina Hodges, who is the IT program manager for the Unitas implementation. I know I went through it quick. Is there any questions? Besides a lot of questions? If you come up with any questions, please let myself or Dina or anyone on that Care Compass team know, and we'll get those back to you. So you can go next slide, Alexa. I guess just contact.
All right. Okay, so hi everybody. We're going to talk just a little bit about the anticipated contracting that will be involved for the SCN. As I'm sure you would imagine, we have a few contracts that might be required in order to do the work of the SCN. So Alexa, if you'll just go to the next slide, I'll overview that at a high level. So we don't yet have contracting templates from the state, but we do anticipate some form of an participation agreement for organizations to take part in the work of the SCN. This would allow for entry into the SCN. It contains all that legalese that's required, and then it will outline obligations of both the SCN and the participating organizations. Under that participation agreement, we anticipate at least one SOW, and that may be more than one depending on what the structure of the organization work that's going to be done. And then it will also have payment terms and any other of the specific obligations in the work that'll be done by the organizations. Sure, thanks Jasmine for attending. As well as the participation agreement and SOWs, we're going to have a BAA, which would just outline how any of the information that's being shared will be protected, both PHI and PII. We also have data use agreements that will need to be in place, and that will help outline how we're going to use data, how we're going to share data amongst both of the parties. We may already have a DUA in place with you or a BAA in place with you, and we're evaluating whether or not we'll need other DUAs or BAAs, but we'll be in touch with you about that. And then outside of the agreements that we would have with your organization, you may also be entering into agreements with the WIO and the RIO. So you may already have participation agreements with the RIO, but so you may already be set with that. But if you don't, you would be entering into some form of a participation agreement with the RIO. And in those agreements that we are going to have with you, we're going to have certain requirements such as protections around fraud, waste, and abuse. Maybe have outlining that you need to have a fraud, waste, and abuse policy. As well as that, there will be different privacy and security policy and training requirements. And then also requirements for adoption and integration of the Unitas platform. Now, if you are looking for certain policies and trainings, we do have those available under our open network services. So if you are looking for certain things around the trainings and policies, once you see what those are in the agreements, please reach out to Mira, and she can help you with those policies and certain trainings that we have available. I think there were a couple chats here, just make sure I didn't miss anything. Will all participating or have to be Medicaid enrolled providers? I don't have I don't have the answer to that right now. Mark, do you know the answer to that?
I believe that's a no. The social care network needs to be an enrolled Medicaid provider. We've already begun that process. So the social care network would be a Medicaid billing agency, but not each individual CBO partner within the network.
And then the other question from Andrea Herodon, will the organizations that serve the other counties in Care Compass territory, such as Steuben, Schuyler, and Chemung, still be able to be included in any way? So,
Yeah.
go ahead,
We're
Mark.
having active questions on that, Andrea. That's obviously a lot of you are here. Some of you don't work in this region in full or in part, and that's a question that we would need to have with the state. There is some language in the operating manual that puts restrictions on where services can be performed based on where a Medicaid member is attributed to. But then also, we would need to coordinate system interfacing. So from a Care Compass collaborative perspective using Unite Us, the Syracuse Central New York region, my understanding, is also going to be using Unite Us, as is the Capital District, which would be directly to our east, as is the Hudson Valley region, which is immediately to our south. So any organization that spans and covers over, let's say from Broome, Tompkins, but then up into Cortland, they would be offered the same system from social care networks. I don't believe the Finger Lakes region is using the Unite Us platform. I think they're using Find Help Now, but I'll let them share that information, but I'm pretty sure that's the one they're using. So if we were to actively coordinate or collaborate with organizations that work in other counties, we would need to make sure that if that agency was to use the Unite Us instance through Care Compass, that it could also meet the needs of Find Help Now and properly interface. So we are having those conversations. I don't have answers yet, but that is something that we're actively having questions on.
Okay, so we have a question from Michaela. Can you explain RIO? What does that stand for? So RIO is the Regional Health Information Organization. That would be Healthy Connections, or another organization, depending on where your area is. But for our area, that would be Healthy Connections. And if you haven't already contracted with them, you can reach out to them and start that process. And see another question from Trudy. Oh, the question about the private, not-for-profit or for-profit organizations to help Medicaid patients. As Mark had explained, where we don't have a not-for-profit that is offering services that are required for the SCN, we can work with for-profit organizations to provide those services. And we are working on a methodology to be able to get those services provided by for-profits where needed. Rick Bolin asks, will the scope of the DUA be limited to those individuals receiving HRSN related services versus chaseless? The DUAs are currently drafted such that they are for the purposes of the services that are being provided, not only for the HRSN services for the SCN, but also other activities that Care Compass is involved in with organizations where data is exchanged. And do we know who the hero is going to be? Mark, I'll let you talk to that one.
Yeah, I'll let's let the questions keep rolling in, but I want to just share this one last slide, and then we'll try to gather these questions and answer them all at the end if people want to stay on, and we'll record it. But just knowing some people have hard stops at 1 o'clock and we're exceeding that time, I just want to share two last quick slides. This one shares a little bit about the expected timing. We're in the same position that Tasha is in that we don't have some things lined up yet. So really critical, and what we're hoping very firmly to get done in the August-September timeframe is the various contracts between the Social Care Network and New York State, the MCO. We are awaiting the finalized operating manual and fee schedule. Those are really critical to help organizations understand what services they want to provide. We also need to fill out some governance, some areas of representation on the Care Compass Collaborative Board. So you'll be seeing some notices for that coming out as well. And also, once those things, well, not the governance piece, but once the operating manual and the contracts are done, we can then begin contracting with CBOs. So we're really hoping maybe by late September, we can start contracting with the CBO networks. And once those pieces are in place, October, November, December is where we'd like to see the Social Care Network receiving the startup funding from the state, begin training, potentially with Tasha, Social Care Network navigators, some CHWs. We'd be happy to collaborate with you on that. Start distributing the infrastructure funding so organizations can build new services, expand capacity, all those kinds of things, and also go through the onboarding and integration work with Unite Us. And then by January, that's where we would begin receiving the per member per month payment that's going to pay for the enhanced services, begin deploying the enhanced services, reimbursing for them, and all those kinds of things. There's a lot more underneath it, but this is just the high level framework. You're not behind if you think we don't have a contract yet or anything like that. So this just helps level set some of the early milestones and approximate timings that we hope to work things in by. And then Alexa, last slide. These are some helpful resources. These will come out. We've shared a lot of information today. We have the two WIOs, and Tasha, I hope I have the county allocated correctly. New York State has also created a website for Social Care Networks. This is where they're posting all their official content. So just wanted to call that out. We've also created a Social Care Network help desk email. So if as you're reading through the document, if you're hearing things within your organization and you have questions, please share them. We want to review them, do Q&A at future meetings and publish some of the responses and be responsive to you on that. So if you do have questions, please share them and let us know. If you have questions or would like to make further inquiries on the Unite Us system, Dina Hodges, and Dina's here today. Dina, her email is there, and she can help you navigate the Unite Us exploration process. And then also, as Andrea said, we have an open network. This is where you can get access to a lot of policies and templates and different things. Many of you have taken advantage of it. We just had a training on site today that a lot of people participated in. But I did just want to get these out and make sure you knew that these resources were here. So we'll share all of this and get this out to you so you have it. And we'll be having more workshops today. But this was just big level vision, and we'll be going more specialized in the future. And as Ken said, just even overviews on Unite Us.
Mark, this is
Yeah.
Tasha from Iroquois Healthcare Association. So Tioga and Tompkins counties are included in the Iroquois system. That's the mistake DOH made on the map.
Perfect. We'll update that on our side too, Tasha. Thank you.
Thank you.
So there was one question that had come in the chat that I want to speak to was the hero. We don't know who the hero is going to be, but there is going to be statewide participation. We don't know how that's going to work yet, but when we find out how we can get local representatives on maybe a regional task force or a review team, we would make that available to the team. There was a question that Karen had shared earlier, and thank you so much, Bob, for working your way through the documents. It does look like grab bars and pathway access is something that would be reimbursable. Again, so long as separate conversation on what is the eligibility criteria, but for people that met the eligibility criteria, it would be involved. Okay, I'll give a moment if people want to put more questions into the chat or grab the SCN help desk email and send them forward. But for that, for today, we'll call that a wrap. Thank you so much for joining, and we look forward to having more workshops, even some in-person ones. But just to get started, we wanted to be able to have a quick Zoom meeting and get everybody together. So thank you so much for joining, and we'll talk to you soon.